So hypospadias is a disorder of the penis. It usually occurs at birth. When you get it fixed, it just depends on multiple issues that can occur with it and parental decision. So I fixed it when they have been 3 months, 6 months, all the way up to probably a 38-year-old. To this day, I'm not really sure why it wasn't fixed when he was a child. But anyways, today, that's what we're going to talk about. So if you have a curvature that is that bad, all the moves I do is not going to be able to straighten that penis. If all I did was to bring the hole back to the tip, I would be doing your son a disfavor. And you, as in, like, if you as an adult male or a teenager has the problem, probably 99% of the time hypospadia is fixed when they're younger. So in that case, what I actually have to do is I actually have to cut the urethra. And by cutting the urethra, it will allow the penis to be straightened up. And then I still have to put in the stitches and I still have to perform the fairy cuts and all that. But by doing that, I am able to at least straighten out the
We
penis.
gon' do it like it's priceless. Take it to the moon. Priceless. One day will be soon. Like it's priceless.
Hi everyone, welcome to another episode of D Talk with Dr. Pham. So today I'm going to be talking about hypospadias. There seems to be a lot of interest with this, so I got some emails and messages sent to discuss this topic. So hypospadias is a disorder of the penis, and it can occur, or it usually occurs at birth. When you get it fixed, it just depends on multiple issues that can occur with it and parental decision. So I fixed it when they have been 3 months, 6 months, all the way up to, I think the oldest one I've done it on is probably a 38-year-old. And to this day, I'm not really sure why it wasn't fixed when he was a child, but anyways, today, that's what we're going to talk about. So, but before we can understand hypospadias, let's just go over normal penile anatomy. So a penis is really just supposed to look, okay? So a lot of people can, they look at a penis, they can tell you it's a penis, but when you ask them to name the different anatomy or proportion, they're not really able to do that. So we're going to go over that first before I kind of go over what hypospadias actually is. And I don't like to use the word abnormal. So in a non-hypospadias, basically the meatus, the urine channel occurs at the tip, is a rim called the coronal rim. So it looks almost like a mushroom head. And then right below there is something called the inner preputial skin, which is that little pink skin that you kind of see. So the penis actually does have proportion. And then you have the penis skin, and then you have the scrotum. So we'll just kind of do some rugation to kind of represent the scrotum. So in a hypospadias, what happened is, let me just make it blue. What happened is the hole actually doesn't occur at the tip, but it can occur anywhere along here. And so the theory all the way to the scrotum. And so the theory is somehow during development, the urethra just doesn't get formed where the hole is at the tip. And most of the time, but not all the time, hypospadias occurs with something called Core D, which is a very different etiology, okay? And I'll go over Core D briefly, but what Core D is when the penis is basically, so this is assuming a penis with no hypospadias. So the tip is normal, but what you end up having is curvature. And typically, if the curvature is around 30 degrees or so, then that's when we fix it. And then how they normally present, like in a true Core D, well, I don't want to say true Core D. A lot of Core D presents with, and then we'll just do the scrotum right here. A lot of Core D actually present with something that looks like this, and then you have like just a little bit of skin. Why don't we just change it to red? You just actually have some skin that kind of just covers this part. but there's no skin here. So I'll just put no skin. And so that's a sine qua non of, or presentation of Cordy. And so hypospadias typically will occur most of the time with curvature or chordee, but it doesn't always have to. And the vice versa is true. You can have curvature of the penis without having hypospadias. Now, not all curvature requires that you only have partial foreskin. And this partial foreskin is actually called, it has a name. It's called a dorsal hood of the foreskin. And the reason why, and it'll be very obvious once the child's born, because even if you wanted to do a circumcision on it, you won't be able to. And the reason why 30% cutoff is not really an insurance cutoff, it's more of kind of what the consensus is among pediatric urologists, where we think a 30 degrees curve can cause difficulty with penetration. And so to fix curvature, let's just assume the patient only has curvature, then it's very easy. What I do is in the operating room, and if you're under 12 months, basically we can do it with just a spinal anesthesia. And I'll talk about spinal anesthesia in my next episode. But with spinal anesthesia, basically the patient is actually not intubated. And the hospital that I performed the surgery at is actually the only hospital in the city that I know of that performs spinal anesthesia in children under 12 months. So, and that, I think that really has to do with time, because when you have to train residents, which I do train residents once a month on a Friday. Basically, if you train residents, typically in spinal anesthesia, it's similar to an epidural, but a little bit safer because the block is lower. You only have 90 minutes to 120 minutes to complete the procedure. So when you're actually training residents, you kind of have to let them do some stuff. And so when they're actually having to do some stuff, then you're going to run over that time. So the baby is going to start moving. And so that's the reason why the majority, I do about 800 cases a month, and I really only do about 3 or 4 cases a month that, that residents are involved in. The rest, parents really just want Dr. Pham to do it. I guess because they call me the penis king. And so, but to correct curvature is very simple. All I do is I actually peel the skin down like a banana. And then what I do is I inject it with saline. And once I inject it, I will actually know the exact curvature. And of course, I'm going to take the skin back here down, because the skin back here is actually causing the penis to look less curved than what it really is, because it's pulling this way. Once you actually take the skin down, you're really going to see the curve. And the theory behind that is the penis is really just 2 cylinder and a urethra. So if the cylinder on the underside of the penis is shorter than the cylinder on the top side of the penis, then that's what causes the curvature. And so to fix it, especially in children before puberty, it's actually rather simple. What I do is I inject it, and then I will know how much it curves. And then what I do is I look at something called a point of maximum curvature. So meaning, where does it curve the maximum? So let's say if it curves right here, then what I do is I put a permanent suture in that you won't be able to see. And the only thing you'll feel is a knot. And most of the time, 1 suture is enough. Sometimes I need to put 2 sutures. And what that does is it will actually cock the penis back this way so that the penis now will be straight. And by doing that, it will stimulate the bottom or the inferior side of the corpora to grow. And so then success rate in my hands almost 100%. And so actually, I don't even remember when I have to take a patient back to actually have to fix it again. But if you do it right, then what ends up happening is the penis will be straight. But once the penis is straight, if you notice in isolated chordee, there's no skin here. So once you straighten it, there's going to be a skin defect. So what I do is this skin right here, I'm actually going to split it in half and I'm actually just going to rotate it around and it'll cover the penis. So the end result is you will just have a penis that looks like this. A lot better because, like I said, I'm no Monet, so I'm trying to draw the best I can, but you'll have a penis like that. Okay. And recovery, usually I fix these when they're around 3 months. Now, in term babies. Now, patients have always asked me, well, doctor, my pediatrician told me, I should wait 9 months, 6 months, 1 year. So when I first started, I actually asked the chief of anesthesia, where's the data that says you need to fix it at 6 months or 9 months or whatnot? Well, in a term baby, basically, if you fix it at 3 months or 6 months or 9 months, there's actually no detrimental issues. And what I mean by that is the reason why usually pediatric urologists are affiliated with academic centers. So if you're going to train residents, it's much easier to train them when the penis is bigger and also the IVs are larger so that anesthesia residents can, it's much easier for them to do it versus when you do it at 3 months, everything's harder, but I don't use residents. I use attendings only. And so that's where the 3 months cutoff come from. And so when you hear about 3 months, 6 months, 9 months, that's purely the reason. But from a clinical standpoint, it really makes no difference. And if anything, the younger you are, so i.e. 3 months or above, the easier it is for the anesthesiologist to actually perform the spinal. And we'll talk about spinal in another episode, but basically with spinal, you don't run the risk of any airway issues. And the anesthesiologist that I've worked with, when we do spinal, just total case number, I'm guessing at least around 400 or 500 cases. And our complication rate that we've seen is 0. Versus with intubation, the complication rate is still very low, but it exists. And so if you have an alternative with the same results on the penis, then, why not go with the safer alternative? And then in my experience, parents, once they go on www.crescenturologyinstitute.com, because I'm the only surgeon that offers spinal, there's a banner on top that actually goes into just pros and cons of general anesthesia versus spinal anesthesia. And in our experience, once parents read that, they all really want spinal anesthesia. So we've had patients that cancel because somehow there was a miscommunication where the anesthesiologist that can do spinal, he was post-call and so he wasn't available. The parents weren't mad, it's just, it was a wasted day, so I feel bad. But they were happy, that, it got rescheduled and everything worked out well. So that's actually core D. Now, back to the hypospadias. So hypospadias is when the hole doesn't completely occur at the tip, but it occurs anywhere along this line. Now, there's many grading system. I mainly just use a clinical grading system, as in if it occurs kind of here or above, I call it distal. If it occurs kind of here or all the way to kind of, maybe here, I call it mid shaft. And then if it occurs kind of anywhere along here, then I call it proximal. And the reason why I do it like that is because complication rate directly ties into where the hole actually is. And hypospadias is one of the very few, if probably the only one that I know of, besides stage orchidopexy, that is time dependent and length dependent, and or width dependent. And what I mean by that is because in order for, let's say you have a hypospadias, the hole is forming here. Then in order for me to correct that, I need the gland's penis to be a certain size. Because if it's not big enough, I won't be able to tubularize it or basically close it like this, okay? And so there's nothing artificial that's being put in. And so, but in order for me to close it, I just need the glans penis to be at least 15 millimeter or so. Now, could you do it smaller than that? Yes, but why? The baby's not really going to be using the penis right now. And in my experience, under age 1, the pain doesn't really, is not much more than if I did it like at 4 months or 5 months. So hypospadias, I usually don't fix those until at least the head of the penis is a certain length. Versus curvature of the penis, it doesn't matter. I can fix it at 3 months, 4 months, 5 months. It's all the same. Hypospadias, on the other hand, is different. Now, sometimes when the hypospadias, in my experience, if it's distal, then you can get cases where there's no curvature involved. And so with that, basically once the width of the glans penis or the head of the penis is large enough, then I can roll it together. And I typically don't leave a catheter, but I make that an intraoperative decision because catheter can lead to its own issues, pain, infection, whatnot. And so there are studies that have already been done that shows that you don't necessarily always need to leave a catheter. So what I do is after I fix them, I do something called a Credé maneuver, which is I press on the abdomen, and if I see a good urinary stream go out, then I don't leave a catheter. However, if I press on the belly and the stream is kind of thin and not coming out as what I like, then I leave a catheter so that it can heal around that catheter. And we come a long way with medication to help with catheter pain, and so they still do pretty well. But it does lead to infection. Although rare, it can happen. So I try to do what I can to try to decrease the risk of infection. Now, if you have mid shaft or proximal, those I tend to always leave a catheter just because I worry that you get swelling and all that, and then the urine's having a hard time coming out, and then next thing you know, they can't urinate. A catheter has to be put in after the fact. That increases the risk of anastomosis breakdown and fistula and whatnot. And so, for me now, and so basically, if it occurs in isolation, then all you really have to do is basically the concept of penis surgeries is always I peel the skin down. And then what I do is, let's say the hole is right here, or even if it's here, then what I do is I just kind of tubularize it so that now I bring the hole up to the tip. And I'm not one of those that's overzealous about making a hole like so distal or to the tip that it can scar down. So I try to make it an oval shape. And then if they have curvature, then we fix it. Now, when you have a mid shaft or what I call proximal hypospadias, typically those will occur with curvature of the penis. And so if it's a curvature that I can just inject saline and maybe put 1 or 2 stitch that will keep the penis straight after, because after I put the stitch, I'm going to retest it to see if it's straight. Then if that's the case, then after I straighten it, then I just tubularize it, like kind of how it doesn't matter where it occurs, you tubularize it the same. However, you're going to have cases where the curvature is just really bad, that basically if I don't make the penis straight and all I did was bring the hole to the tip, that penis is not going to be functional because the shape of the vaginal canal is kind of in and up. If you have a penis that's kind of like that, over time, most likely it is going to get worse and it just becomes harder and harder to fix. And so for me, if I have tried every single method to straighten out that penis, such as the sutures is one, I can also do what we call fairy cuts, meaning that on the cylinder, I kind of make little superficial cuts like this and allow it to straighten itself out. And if that works, then we do just a 1-stage hypospadias repair. However, If I use stitches and I do fairy cuts and every single maneuver I have under my armamentarium and the penis is still curved, then unfortunately that patient will undergo something called a stage procedure. And what that means is the penis is going to be curved like this. And soon I will upload pictures onto the website so that basically you can see it for yourself, because we really can't upload real pictures even though patients have given consent. It's just the way the algorithm is, they will block the penis showing. So if you have a curvature that is that bad, all the moves I do is not going to be able to straighten that penis. And if all I did was to bring the hole back to the tip, I would be doing you or your son a disfavor. And you, as in, like, if you as an adult male or a teenager has the problem, most of the time, probably 99% of the time, hypospadia is fixed when they're younger. So in that case, what I actually have to do is I actually have to cut the urethra. And by cutting the urethra, it will allow the penis to be straightened up. And then I still have to put in the stitches. To this real quick. I still have to put the stitches back in, and I still have to perform the fairy cuts and all that. But by doing that, I am able to at least straighten out the penis. But because I cut the urethra, we'll use purple to shade it in. There's a defect right here. So let's just use red. So this is the distal, or the end of the urethra closer to the head of the penis, and then this is the one closer to the scrotum. So then now, where am I going to get the tissue that will act like a urethra that I can basically connect it, so that basically in about 6 months or so, I will then bring the patient back. And then at that point, then I can then roll the tube. And the reason that is because the way the graft that we use to place it, it undergoes a healing process called imbibition. And what that means is it doesn't have a vascular pedicle that comes with it. What it does is it attaches to the corpora itself, and then the blood supply that's going to keep it alive or keep the graft good is actually going to come from the corpora and the surrounding blood vessel. And that's why after surgery, I always put a bolster on it. And there's other techniques that I do to keep that graft on there. So if it's a case where the patient has never had surgery, there is a skin here called the interprepucial skin that resembles urethral skin. And then what I would do is I would take that skin and put it in here, and that will become your urethra, your new urethra. Okay. Now, if you've already had surgery and there is no more interprepucial skin, then I can get tissue from the mouth. And the reason why I like mouth tissue, if I don't have this as an option, is that the mouth tissue, if done correctly, is unlimited, meaning that you can harvest as much as you want and the tissue will grow back as long as you understand the principle, meaning that, don't cross the vermilion line, don't get into glands that you're not supposed to get into and all that. And we've done quite a bit of these because that's kind of your mainstay of fixing urethral injury, because this doesn't apply to just hypospadias, right? If you get a gunshot wound and it cuts the urethra near the bladder and you don't have enough tissue, you can actually harvest tissue from the mouth to basically replace it. And so, but most of the time, if they do have interprepucial skin, I don't think I've ever ran across a case where they have interprepucial skin and then I end up having to take the patient back because the graft didn't take very well, and then I have to use mouth tissue. The only time I have to use mouth tissue is if the penis was botched in the first place, and then now there's no tissue for me to use. Then I would have to use the tissue from the mouth. And believe it or not, the pain from the mouth probably lasts a couple of days. And we put you on some antibiotics like clindamycin to cover bugs that are in the mouth. And then eventually it'll just heal. And then basically in 6 months, I would then take that patient back and then we would do a what we call a second stage procedure where now that the penis is straight, then I can roll the tube back up. And the other thing I do is around the testicle is a tissue called the tunica vaginalis. And so we'll just mark that with this aqua color. And so that one actually is just a tissue that surrounds the testicle. But that one comes with its own vascular pedicle. So what I do is I just make an incision kind of right here so you don't have a lot of incision. And then basically what I do is I harvest that strip of tissue. And then what I do is when I actually bring the urethra by tubularizing this, I will then lay that tissue on the repair itself. Then what that will do is it will help vascularize that area. And by having good vascularization, that's how you decrease complications such as fistula when you spring a leak, meaning that if a area is not vascularized well, then it'll break down. You'll end up with a hole. And the reason why I don't make this very tight is because if I make it very tight and it scars up, it can cause a diverticulum, meaning that there's a lot of back pressure, which will then cause the urethra here to kind of dilate like this. And so I try to do everything possible to not have to have a third surgery. And then there's stuff off the shelf that I also use to help with healing any sort of peripheral nerves that possibly could have been damaged. That's microscopic, i.e., that I can't see. And then I also there's also tissue. There's also hyaluronic acid that I use off the shelf. That when I close the skin, what it does is it allow the skin to glide without having tethering to the urethra itself. And by doing that, when the patient gets an erection, the skin doesn't get stuck to it. It'll allow it to glide. And so far, we've done probably 700, not particularly hypospadias, but just penis in general. Just off the top of my head, probably around 600, 700. And the results when you use off the shelf stuff like hyaluronic acid and stuff, their results is always better. And then now, if I do a stage procedure, then what I do is I always leave a catheter, just about 3 days, and then I also leave a bolster because what the bolster does is it's gonna press on the graft. So let's just pretend like we haven't. Here we go. Let's just pretend like we only put the graft in, right? Then what I do is the bolster actually will just be like basically a dental roll that I put zero form around, and then I just suture the this part and this part together so that I can tie the bolster down. And what the bolster does is it's going to press on the graft itself to allow the healing process to occur. And usually that I take out at around 14 days. But a lot of times, what I've noticed is once the swelling goes down, the bolster kind of falls off. And I've noticed it really doesn't make a difference in terms of the graft taking. And then the catheter, I just kind of remove in around 3 days because the catheter can be uncomfortable and all that. And so, like I said, our success rate with second stage without having to do anything is probably going to be around 90% or so. And so, that, I hope that kind of help everyone kind of understand hypospadias as well as core D and how you fix it. Now, these are all outpatient surgeries, so none of them really need to be admitted, okay? And so the care for it actually is very simple too. If you have a first or second stage hypospadias, then I do something called a double diaper. So first, on all penis cases, I always leave a dressing that kind of covers the penis itself without covering the tip. And the reason why I do that is to prevent swelling in the first 72 hours. And by doing that, it will help prevent wound breakdown. And so the patient, if the patient doesn't have a catheter, he just urinates like normal. If the patient does have a catheter, then what I do is double diaper just means we put a first diaper on so that it can capture the stool. And then what you do is when the catheter comes out, it'll be, there we go, it'll be taped to the first diaper, and then a second diaper will be put on so that urine and stool don't mix. And hopefully that decreases the risk of infection. For curvature of the penis, obviously I don't leave catheter because we don't need to, because we didn't do anything with the urethra. And so same concept, I still put a dressing that I have parents just sponge bathe the baby, or if it's a patient, I have them sponge bathe for 3 days, and on the third day, you kind of just put them in the bathtub. There's only 2 dressing. You just unwind it, and then that's it. You leave it alone. I also put Dermabond or glue on all the incision site, and the reason why is that'll help kind of keep the area clean, but you don't put Vaseline or anything directly on it because it will dissolve the glue. So what I recommend to parents is if they feel like the head of the penis is sticking to the diaper, then just apply Vaseline to the head of the penis, or they can put Vaseline on the diaper itself. But the only thing I worry about that is that when you put Vaseline directly on the diaper, you can't control where that Vaseline goes. And last thing I want is for it to dissolve the glue, because the glue will dissolve itself in about 7 days. And what I found is that 7 days, the skin's kind of closed. And so you're kind of quote unquote out of the danger area for a little bit. And so basically, I hope that makes sense on hypospadias repair and cord E repair. And so if you like to see future episodes like this on any topic, then please subscribe. We are on Apple Podcasts, Spotify, YouTube, Facebook, you name it. And so help me continue doing this by subscribing. Okay? Until next time. Thanks for watching.